Okay.
Yeah, we can start. Good evening, everyone. It's my pleasure to invite you all to ISA National Online PG classes. These classes will be held on every Monday at 6:30 p.m. I myself, Dr. Lavanya, working as consultant at Sunray Hospital in Anantapur, Andhra Pradesh. Today, I will be one of the screen coordinator along with Dr. Farin. So, the today's topic for discussion is on the diagnostic capnography and its clinical challenging scenarios. This is the part 2. Actually, the part 1, which is on the basics of capnography, was discussed on January 20th, 2025 in the ISA National Online PG class platform. So, those who have not attended part 1 can go on to the YouTube website ISA National Online PG class and know about in-depth in capnography and its importance. So, with this being said, after learning the basics of capnography in the previous class, now it is the time to recollect and discuss some clinically challenging scenarios where capnography can prove to be a life savior. These diagnostic dilemmas will be discussed in detail for today's class. So, let us now commence this session by invoking the blessings of the divine as we meditate on the Saraswati Vandana. Now I request our ISA National Honorary Secretary, Dr. Sukhminder Singh Bajwa sir, to address the audience.
Thank you, Dr. Lavanya. Today, actually, this class is an extension of our previous basics of the capnography. And I think many of the people who must have used the capnography for a long time, they must have encountered these type of clinical cases scenarios. And these are the real scenarios where we always see the capnography having, analyzing them properly. You can do wonders to a patient, saving a patient's life. These are very, very important clinical scenarios, and I think Dr. Hital will be doing the justice again the way he did in the first class. So it will be he will be making it very interesting also. And I can see my two GC members, Dr. Hina and Dr. Ramakrishnan Reddy are there. So I like to give them opportunity also so that they also speak about it before starting the. Dr. Rama, you please tell what you want to be seeing in this class.
Good evening, Honorary Secretary Dr. Bajwa sir, and Hina and my long-term friend Hetal, all the audience. Good evening, good evening. And he's my quiz colleague also. So I didn't attend the first session, but I think I don't know what are the things you are going to present today, but it is a very important topic for all the postgraduates who are going to attend the exam. And I'm very happy to be a part of this class. Thank you.
Yeah, thank you, Dr. Ramakrishna Reddy, sir. Dr. Hina?
Yeah, good evening, Honorary Secretary, sir, Madhuri Madam, Ramakrishna Reddy, sir, and Dr. Hetal, sir. The part one, it was a very useful the lecture regarding the basics of ETCO2. And now today is, I think so, the clinical implications of ETCO2 regarding the case scenarios and all that. And it is very useful for the PG residents. And as per the monitoring part, it is now compulsory ETCO2 in the each operation theater. So it will be useful to not only the resident, but for faculties also it will be very useful. So all the best, Hetal, sir. Thank you. Thank you,
Yeah,
Bajwa.
thank you. Thank you, Dr. Hina.
Thank you, sir.
Back to Lavanya. Start the
Huh.
proceedings.
Thank you, sirs and ma'am, for your words. Now I invite my co-screen coordinator, Dr. Farheen Rahat, to introduce the faculty and also to outline the session format and rules and carry the session forward. Over to you, Dr. Farheen.
Good evening, everyone. My name is Dr. Pareen Rahat. I'm currently working as senior resident in KMCT Medical College, Calicut. It is my pleasure to introduce to you all our esteemed faculty for today's session on diagnostic capnography, clinically changing scenarios. Dr. Hetal Kumar Shah. Sir is a senior consultant cardiac anesthesiologist in NH Multi-Specialty Hospital, Ahmedabad, with specialty interest in high-risk surgeries, cardiac patient for non-cardiac surgery, airway, pediatric cardiac anesthesia, capnography, and lung protective anesthesia. He is a recipient of the prestigious Dr. Devi Shetty's Award for Outstanding Doctor and Dr. KOP's Award. He has been one of the quiz masters for ISA online quiz competition. A warm welcome to you, sir. Before starting the session, let me briefly tell you the rules for the class. Firstly, keep your videos off and your audios will be muted during the session. Secondly, if anyone has any doubts during the session, kindly type them in the chat box. Towards the end of the session, all those queries will be answered. Now I request our faculty for today to kindly take over the session. Over to you, sir.
Good evening, one and all. Good evening, Dr. Bajwa sir, Dr. Hina, Dr. Ramakrishna Reddy sir, and my moderators for today's Lavanya and Rahat. I'm just trying to share my screen meanwhile. So, as been told that this is the part 2 of ETCO2. The first, is it coming full screen?
Yes, sir.
Yes, sir.
Yeah, perfect. So the first part we understood how the ETCO2 waveform is getting formed. What makes this part phase one, phase two, phase three, and phase four, and we understood it nicely. So I'm hoping that the people who have attended the first class would be able to understand today's class in a very depth manner. However, it will be useful to everyone, right? And today I'm going to take up with the clinical case scenarios, which has actually happened or created in my OR, and various kind of different waveform of this kind of things which you'll be seeing. And from those waveform, can we able to reach to the diagnosis that what was happening to the patient, right? So understanding the waveform is not important, but I mean you can find that this is an abnormal waveform, but could that waveform can lead you to the diagnosis that what actually is happening to the patient. And I can tell you that ETCO2 is one of the best marker for understanding early any abnormality which is going on in perioperative period in a patient. So that is what we need to understand. So the topic is abnormal waveform analysis, and these are certain disclaimers that majority of the images and photos are original. They've been taken during OR, so probably the quality of the photos probably you may not get that great. Certain situations I have created, and it could not be the real-time scenarios, but the whole motive of that is purely educational purpose. And I am here no one to say that any technique or any method is superior or inferior. We are here just concentrating on ETCO2 abnormality, and from those abnormality, what could be the probable diagnosis or what could be the probable pathophysiology which is going in the patient, which we need to rectify. Right? My voice is audible,
Yes.
Yes, sir.
and there is a surprise for all of you. It's a Taddy Day today. of a Valentine's week. So, and because it's in a online class, so you will get a virtual teddy, and Rahat and Kathi will note down. There will be a clinical scenarios which will be putting, and probably will some few seconds, 30 seconds will be given to you to diagnose that. Whosoever is diagnosing for the first time, fastest finger first kind of scenario, and who will be doing for most of the time will get this virtual teddy free. Let's begin. So what we do in when we give any anesthesia to any patient, right? We initially starts doing pre-oxygenation. So during pre-oxygenation, what happens to the EtCO2, right? So on a spontaneous ventilation in an adult patient, you can get this kind of waveform of the EtCO2. This is not typically squarish waveform. And the reason being this not being a squarish waveform could be multiple reasons. One could be that there will be no tight leaking, and tightness of the mask which is happening. There will be some amount of leaking which is going to happen because patient is just getting under anesthesia. So you may not be able to hold that mask properly. Secondly, they will start getting induced, so their respiration will become jerky. So later part of that, you will find seeing some deep in the EtCO2 height, right? Depending on their ventilation. So you get this spontaneous ventilation in a non-obese patient, you will get this kind of waveform, not the typical squarish waveform. What happens to the obese patient? So when the obese patients start doing spontaneous ventilation, you will not see the differentiation between the phase one and phase two and phase three, right? So phase two and phase three looks the same, and this happens because the obese lungs will have some amount of restrictive pathology, and this restrictive pathology leads to this kind of waveform in a spontaneously obese ventilating patient. So this from EtCO2 you can diagnose. If you just have a EtCO2 and you know that this is a spontaneous breathing patient, you can diagnose that this patient would be obese or not. So that is one thing. Okay. Once we induce the patient, we give relaxation and then we intubate those patients. And sorry. And then once you intubation and ventilation is started, you can get this kind of squarish waveform. Typical phase one, phase two, phase three, and phase four, right? With the baseline at zero, right? So this is the typical squarish waveform for disorder you should be getting, right? Great. Now, there are certain times we keep patients under anesthesia, sedation, and but the patient is ventilating spontaneously, right? We may not intubate those patients. We don't put supraglottic devices. We just keep them on a spontaneous ventilation. And on a spontaneous ventilation under deeper or mid plane of anesthesia, the respiration becomes smooth, and then they will have a inverted U wave kind of EtCO2 graph. It will not be the squares. It will be inverted U wave kind of thing because that phase four is lacking in those kind of patients. So you will get this kind of waveform in a spontaneously ventilating patients under deep sedation. Okay, so I'll be throwing certain clinical scenarios. How you should approach in this is first you identify the capnograph. You read the capnograph, whether the graph is normal or abnormal. Then you look at the capnometry reading, whether the capnometry reading is in the normal range, right? As you know, the range is between 35 to 40, right? Which phase has a problem. See, then you find out that if the capnograph is abnormal, if your capnometry is not in a normal range, then you find out that which phase has a problem. Whether it's a phase one, phase two, phase three, or phase four. And then you try to identify that problem can be at cellular level, that is metabolism, which is at a stake, or it is a perfusion level problem, or it is a ventilation related problem, or it is a equipment related problem. So in last class, we nicely understood that EtCO2 can tell you the abnormality in ventilation, in perfusion, or in a metabolism, right? And overall on equipment also, because under anesthesia, there are a lot of equipments are also coming in the play, right? So you can actually diagnose all of this, and we will try to solve in each cases. So this is the first scenario. Okay. And guess what? Your 60 seconds starts now. You have to write in a chat box what is the abnormality. This will blink for 60 seconds. Only one answer till now. Yeah, great. Some answers are coming. So this is the waveform. So you can identify that the waveform will look normal squares, but the capnometric reading is high, right? Okay. So this is a possibility of the high EtCO2 scenario. What condition we really don't know right now. So high EtCO2 can happen with the two conditions. Patient with adequate ventilation, you can have a high EtCO2, and patient with hypoventilation will definitely will have a high EtCO2, right? The patient who are not ventilating at proper, let's say some patient in in a deep comatose state, breathing at or some neurological condition, breathing at a respiratory rate of 6, definitely you can have a high EtCO2 in those kind of patients. But what are the conditions in adequate ventilation? Because this looks like an adequate ventilation. In fact, this looks like a hyperventilation kind of scenario, because your respiratory rate is roughly around 18 to 20 in this. From this CT score, we can find out. So patient is getting good adequate ventilation with good tidal volume, with good respiratory rate, and minute ventilation is good, and still it is getting a high EtCO2. So what are the chances of high EtCO2 with adequate ventilation? One is hyperthermia, because high BMR, metabolic rate would be high CO2 production will happen, and that will cause a hypercarbia. And you can diagnose that from looking at the temperature in a basic monitoring which we do, and you can see that the patient's temperature is high, right? Second scenario, where you are doing a laparoscopic surgery and CO2 insufflation is happening, and those CO2 is coming into the circulation, and this kind of scenario will cause high CO2, high EtCO2 in your capnometry. Sometimes it could be equipment related. Probably not the zeroing was not done properly, or there is some faulty mechanism which has happened, or the sensor would have become malfunctioned. So these are the three clinical scenario where adequate ventilation can produce high EtCO2. Hypoventilation, obviously you can diagnose from the respiratory rate, and you have to just correct one of the things which you can diagnose, and we can correct this, right? Ready for the second? This is the second scenario. Guess what? Time starts now. So this is a scenario where you can see the graph is okay, right? Graph looks okay, but the capnometric reading is very low. So this is the scenario where you have a low EtCO2, right? So this is a scenario where it is a low EtCO2. Why not going? Yeah. So the low EtCO2 is the diagnosis. Now, again, there could be two scenarios. If the patient is hyperventilating, let's say an acidotic patient who is having a high respiratory rate, so then in that case, CO2 can get washed out and then can cause low EtCO2. But here looks like that the patient is ventilating quite normally, right? The respiratory rate is not very high. So with adequate ventilation, adequate minute ventilation, your respiratory rate is normal, your tidal volume is okay, and then it is causing low EtCO2. What could be the clinical scenarios? Hypothermia. Your BMR has gone down, your CO2 production has gone down, and that's why it is causing a low EtCO2. So hypothermia, or a patient who is getting cooled down with low BMR can cause low EtCO2. Or it could be low cardiac output scenario, where your cardiac output is low, so there is no perfusion which is happening to the tissue, and those tissue, the CO2 which is there in the tissue is not coming back to the lung, and that's why your the blood which is returning to the lung will have low PCO2, and that's why it is causing a low cardiac output. Now, how can you diagnose with this hypothermia? You can diagnose with the temperature monitoring, low cardiac output. When you see the EVG analysis, will find a high anion gap, high difference between the PCO2 of alveoli and like whatever and the gap of the alveolar CO2 and the arterial CO2 will be very high. So from that you can identify, or it could be VQ mismatch. So certain part of the lung is not getting ventilated, and that is or not getting perfused, and that is causing the low EtCO2, maybe the collapse, consolidation, or hypoventilation, which is happening because of that. Or it could be equipment related. There will be some leak somewhere, or zero is not done properly. So this could be the possibility with the low EtCO2 with the adequate ventilation, right? Next scenario. So this is the patient with the heart rate of 81, pressures of 87/63, CVP of 10, saturation is 100, and your EtCO2 is showing some changes with the 30 is on capnography. Temperature is almost normal, 36.1. So this is what the EtCO2 which is coming. What could be the reason? The time starts now. So this is notch in phase 3. So phase 3 has some notch. 1 minute. I just wanted to go on my mobile also just to know the answers what are coming. Let me just see. Okay. Uh, Somebody has written when muscle relaxant is getting wear off, return of spontaneous ventilation. Good answers. Reversal, curare notch, curare cleft. Okay, fine, fine. Okay, let's see. So this is a notch in phase 3, right? Now, notch in phase 3 can happen in different scenarios. So notch in phase 3 has probably 4 diagnoses. One is curare cleft, surgical manipulation, lung transplant, or kyphoscoliosis. So these 4 can produce notch in phase 3, and all of them you can diagnose from the notch. So first we will take curare cleft, which is the commonest scenario that the patient is coming out of muscle relaxation and probably happening some amount of notch which is happening in phase 3. So the typical characteristic of the curare cleft is it will never come at a single point, right? So let's say there is a notch in phase 3. Here it is coming just after the middle part. This is coming in the middle part, and this is coming at a very late. So the duration of the cleft on phase 3 is not constant in case of curare cleft, because patient can come out and behave differently when they are coming off, weaning off from the muscle relaxation. So notch coming at a different time interval on phase 3 is called curare cleft. So let's see, this is the patient where you can just see that there are some amount of curare cleft which is started coming. The patient, we allowed this patient to come out of the muscle relaxation, and you can see the cleft is not coming at a regular interval. So here it is coming here, it's coming here, but here it is coming at a late phase, right? So this is a little coming out of the muscle relaxation. When they come out of the muscle relaxation, more out, when they get more out of the muscle relaxation, the cleft will start getting deepened. But again, the timing and the deepening of the cleft is still variable. But when they almost are coming out of the muscle relaxation, then it becomes a standard time, and the deep of the curare cleft becomes almost constant. So this is the early coming out of the muscle relaxation. This is still early coming out of the muscle relaxation. This is almost out, and this is the time where patient is about to buck if the surgery is going on, right? So this how you can diagnose this curare cleft from the phase 3. So the tricky point, or the point which you need to understand is curare cleft are notch in the phase 3, but which is not constant, right? So So that's how you can identify that it's a curare cleft. Okay. Regarding kyphoscoliosis, you can get this kind of notch, and this notch is constant. So initially you get this first phase three, then you will have another phase two and another phase three. This is because kyphoscoliotic will have one lung which is restrictive, one lung is fully expanded. So and the alveoli of both the lungs are at a different time frame. So initially the lung which is restrictive will start pouring carbon dioxide into this, and then suddenly the normal lung will also join, and that's how you have another phase two in between, right? So the early part, which is very shallow, and then you will have a typical phase two and phase three. So this is very common in a kyphoscoliosis, where you get an early dip, the plateau is coming little low, and then you have a plateau which is at a higher level. So that is typical of kyphoscoliosis. In lung transplant, what will happen? That now both the lungs are normal, because let's say one lung is transplanted, the other lung is normal, right? So both lungs are now normal. But the problem is that again the one lung is from the donor, one is lung is from patient himself. So again the time of the alveoli will be different. But since both lungs are normal, so you will have a notch which is in the middle, quite in the middle or little early part of phase three, and that will be unique and constant. So your plateau will remain little same, but you will have a little dip into the transplant lung. But the dip is not much as we saw in a kyphoscoliosis patient. So you can diagnose curare cleft, lung transplant, and kyphoscoliosis from notch in phase three. Right. So you get a notch in phase three, you can straightway can relate to the diagnosis. So back to our scenario where we got this leak, we have seen this kind of notch which is coming quite early, and it is quite constant. The time was quite constant, right? And it was coming quite early. But this was not a transplant patient, and this was not a kyphoscoliotic patient, and this doesn't look like a curare clefts to me, right? So what could be the scenario? So when we saw the ventilator, we saw this kind of waveform. So this waveform is not the proper ventilating waveform, and this patient was getting ventilated with the PCV mode, with roughly trying to get the tidal volume of 360. The delivered tidal volume or expiratory tidal volume was 260, right? So when we saw this, that there is a discrepancy which is happening, and expiratory minute volume low, alarm was also coming. So when we saw the bellows were leaking, right? So when we corrected this leak, and the bellows were filled up properly. And then we saw the typical waveform of the ventilator graph, and you can see the tidal volume which we were expected 360, and now the expired tidal volume is roughly around 410, right? So there was a leak which was there, which was producing this kind of waveform, and this was little early, and this was quite constant. So leak is another scenario which is equipment related, can produce this kind of notch in phase three, right? Okay. Yeah. So this is notch in phase three. Okay, you can see the notch in phase three here, right? Can you able to appreciate, right? Tell me what could be the diagnosis. No answer till now. One answer which has come says it's a wow, great. It's a surgical manipulation. And how do you know? So the surgery must be happening somewhere on thorax or in upper part of abdomen. And what you can see is that this is the cautery disturbances which is coming, right? So with this cautery disturbances, there is a notch which is coming. Otherwise, there is no notch which is coming over here, right? So this could be because of surgical manipulation, right? So the fourth, which I kept, I didn't discuss, was surgical manipulation notch. So this is typical, and then you can identify from the cautery disturbances in ECG, and that is the time where you can get this ETCO2 notch. So this is notch in phase 3 because of surgical manipulation. You don't have to do anything in these patients. You don't have to give more extra dose of muscle relaxation, not a deeper plane of anesthesia, not required anything. Correct. I think two people have given the correct answer, which is very good. Okay. Diagnosis. So this is sudden drop in ETCO2. That's the answer. That you have a nice queries waveform which is coming, and suddenly what has happened? There is a plateau, and then there is a sudden drop in ETCO2 which has happened. Right? Now, this could be a dangerous scenario. This could be a very easy scenario also. So there are a lot of issues. I have taken a hypothetical case that a lady which was coming from USA. She has done almost about 18 hours of flight journey, and she was on OC pills. She was coming here for her infertility treatment. She was taking this OC pills, and when she got down on a airport, she slid down and she had a fracture, which has happened in humerus. And the plan was brachial plexus block with general anesthesia on ET tube with IPPV. Since the position was very odd, so patient could not tolerate on brachial plexus block. So we gave general anesthesia to this patient. And this was her induction hemodynamic. Heart rate of 59, 95 by 41 pressure, CVP of 9, 100 saturation, good ETCO2. Right? This was her induction hemodynamic at 9:10. Okay. After a while, around 11:10, the dynamics were 75 heart rate, 84 by 47, almost same blood pressure, same CVP, saturation is okay. But ETCO2, capnometry is showing 24. So what could be the cause? So the cardiac output looks okay because the pressures are not changing, CVP is normal, no tachycardia, right? And the ETCO2 started dropping. Temperature is also normal. So what could be the causes? We'll come to this case. So there was a drop in ETCO2. So there will be a problem with the circulation, that could be a problem with the cellular metabolism, or that could be a problem with the ventilation. Either of this can happen to this patient, right? So what is the problem? Whether the where this the problem is, and where to treat, what to treat in this patient, right? So there are four patterns which is observed in a drop in ETCO2. And from this four pattern, you can actually clinch the diagnosis, right? So which are these four patterns? First is sudden drop to zero. So you are ventilating this patient and suddenly the ETCO2 becomes zero, right? Right? So this is not a dangerous scenario, right? So suddenly ETCO2 becomes zero. We all get panicky. This is not a dangerous scenario. This is a very common scenario which can happen, a technical problem. So sudden drop in zero is a technical problem, right? So either it could be a kinked DT tube, it could be CO2 analyzer which become defective, it could be total disconnection of ventilation, or ventilator has become defective. So it's in a non-emergency kind of scenario. Obviously, you just have to rectify. So there has to be some technical problem with this sudden drop in zero. Sudden drop in zero doesn't happen with any kind of critical scenarios, right? So if the sudden drop in zero, ETCO2 to zero is happening, that means it's a technical problem. You just have to look at those technical things. Ventilator, your circuit, your connection to the tube, whether there is a kinking or whether your ETCO2 has got disconnected or got defective. So this is the classical scenario where you have to not look at the patient, you just have to look at the machines and accessories. Second scenario which can happen, which is the exponential decrease. So the normal ETCO2 is coming, and then there is an exponential decrease. Slowly, there is a ETCO2 is slowly going down within 1 or 2 minutes. It's kind of a CO2 washout curve which can happen, right? So there is a ventilation which is happening, and then suddenly the ETCO2 started dipping to very low level, right? This is called a washout curve, or exponential decrease within 1 or 2 minutes. This is a very dangerous scenario. and this needs an real attention of the patient because this patient can arrest at any point of time. So when you see this exponential decrease within 1 or 2 minute washout kind of curve, it's a dangerous scenario, and you just have to work on this patient, right? So what could be the possibility? It always indicates a sudden disturbances in lung circulation or ventilation. And because there is a slow release of CO2, the passive release of from the alveoli which is going to happen, and that is causing this exponential decrease in the waveform. It doesn't become slowly zero, right? So it is a problem with either ventilation or a lung circulation. It could be circulatory arrest, pulmonary embolism, there could be sudden decrease in blood pressure and low cardiac output scenario, or there is some sudden hyperventilation which patient has done, and then it stops the ventilate in the ventilation. So this can happen in a ICU also, where you have a acidotic patient, maybe liver cirrhosis, diabetic ketoacidosis, or any kind of acidotic patients, renal dysfunction patients. So they are breathing quite acidotically, and then suddenly stoppage of breathing. So this is a sudden disturbance in lung circulation and ventilation, and this kind of waveform needs urgent attention. Your patient is at a risk if you don't treat this patient in seconds, right? Third scenario which can happen is gradual lowering. So you have a EtCO2 maybe around 38, 35, 36, 34, and then there is a step down kind of decreasing of the uh, uh, EtCO2 which is happening. So your curve remains, right? So your curve retains its normal shape, but the height of the plateau falls gradually, right? Curve remains normal, the squarish waveform remains normal, but the plateau which is coming a little deepening kind of thing. So this is indication of gradual hyperventilation which is happening with the patient, or there is a lowering of body temperature which is happening to this patient, or it could be a decreasing body or lung perfusion. Again, it's not on a very alarming scenario, but yes, you probably will have to have some time to work on it. So it could be a gradual hyperventilation, lowering of body temperature, and decreasing of body or lung perfusion, right? The fourth scenario which has happened to our patient. So this patient had a good plateau, which was roughly around 30, and then suddenly the plateau has dropped down to 24, and it remains static at 24. It was not a gradual lowering, right? This is no exponential curve. There is no zero which is happening suddenly, but the plateau has become the graph has become a little lower. The plateau has started coming at 24, and it remained at 24. So what could be the diagnosis in this patient, right? So it's a sudden decrease, but not to zero. This is the fourth scenario. Sudden decrease, but not to zero, right? Now, this can be easily diagnosed with your airway pressure. So if you have a low airway pressure with that, so suppose you are ventilating this patient and the airway pressure was 18 and suddenly this airway pressure becomes 15 with the with the sudden drop and remaining at that level. And if it is a low airway pressure, again with that low airway pressure, that means there is a leakage in the breathing system, or your airway pressure has gone up, right, from 18 to 21 kind of thing. So there could be a partial obstruction, right? So either it's a leakage or a partial obstruction, and that you can also diagnose from airway, looking at the airway pressure. So if you look at the airway pressure, you can identify whether there is a leakage or you need to do a suction or you need to fix up the leak in this kind of patient. So these kind of four scenario which you can see in a patients with a sudden drop in EtCO2, right? Okay, this is another scenario, 12th case, where you can see that there is a peak which is coming at the end tidal CO2 area. So where the phase 3 and phase 4 is joining, you can see this kind of sudden spike which is coming, right? So this is called a tick sign kind of thing, right? And this is the typical of, if you can diagnose. This is a very typical sign which you can see in a certain condition. Any guesses? You can write in a chat box. Spasm is one of the answer. Just come. No, spasm doesn't come in a at a end of expiration and beginning of inspiration. So this is a quite common scenario which happens with the obesity and pregnancy. The pregnant lady will have this small optic or pigtail kind of scenario where you have at the end of phase 3 and beginning of the phase 4, you get a sudden spike in EtCO2. This is because of the gravid uterus causing a lot of pressures onto the lungs, and this causes closes of small bronchi, and those bronchi suddenly gets expired into the gets into suddenly into the expiration, and this is squeezed out. The CO2 is getting squeezed out from the alveoli, and then it causes this sudden spike. So this is possibility with the poor lung compliant tissue or obese chest wall or in a pregnant lady. So this is a typical sign of small optic or a pigtail kind of scenario, which is very common in pregnancy, obese lady in pregnancy or in a very poorly compliant lung. Okay. Third scenario, 13th scenario, we are ventilating with this patient, with the pediatric patient with, no, this is an adult patient with the fresh gas flow of 1 liter per minute. That's a low flow anesthesia. Tidal volume of 400, respiratory rate of 14. Hemodynamic looks fairly okay. And you can see this kind of waveform. This is happening at 10:56. Right? So we found out that there is some problem which is happening with the phase 4. Right? There is some issue which is happening with the phase 4. Right? We saw the ventilator parameters were looking okay. The graph of ventilator was also looking great. It was not having any issues, right? So we thought probably there is some probably some suctioning is required. Some might be some mucus plug is come. So we did the ET suctioning of this patient, and then the graph started becoming squarish, which is at 11 or 2, right? So after suctioning at 11 or 2, we started getting a normal waveform. With the hemodynamics remains still stable, and there was no change in ventilator parameters which we did. We were ventilating with a 400 tidal volume, 14 respiratory rate. Okay. Now, this was happening at 11 or 2. Again at 11:15, we were seeing this. We were started seeing this that there is a disturbances at phase 3 and phase 4. And we are getting some slanting in the phase 4. The beta angle is getting little obtuse. So we thought, what is happening to this patient? Again, the hemodynamics remains same, right? The CVP is wrong because we were giving fluids to the line which we were monitoring. So CVP is wrong here. I mean, it is not the correct one, but the hemodynamic remains almost same. So we thought, what was the problem this thing? And when we checked with the inspiratory valve, we opened the inspiratory valve and we saw that there was some water droplets which was there in the inspiratory valve, right? So this inspiratory valve, water droplet, this is the inspiratory valve, this is the expiratory valve of the ventilator machine. And when we there was some issue which was happening at the phase 4, right? So there is something which was happening at the inspiratory level, right? So when we checked with the inspiratory valve has a lot of secretions or some amount of maybe the soda lime machineries will have some issues, and the soda lime generated some water vapor, and this water was getting condensed in the inspiratory valve. I don't know from where the water has come, and this water was actually creating some problem with the patient. So this was not in the problem with the machine because not with the patient, because our airway pressure were okay. So peak was 18 was maintained. Ventilator waveform were also okay. So then we thought to decide, and when we did suctioning, there was not much of which was coming and it was improved also. So there was no problem with the patient. So we thought, why not to check the machine? And when we checked, this inspiratory valve had water droplets, and this was causing this kind of problem, right? So as I told you, from EtCO2, you can clinch to the diagnosis. Okay. Spotter, 30 seconds. This is an ASCII question kind of thing. Heart rate remains normal, hemodynamics looks okay, saturation is okay, and there is a ETCO2, which is this. Perfect, right? When you look at the FI, you don't have to look at only the ETCO2. You also see the inspired carbon dioxide here. Your inspired carbon dioxide is 6, right? A lot of people have given the good answer, correct answer, and this is most likely because of the exhausted soda line, right? And that was causing the baseline has gone up. If you look at the squarish waveform is coming, but this is not touching to the baseline, right? And your Fi, inspiratory carbon dioxide, is high, and this is the most common scenario which can happen with the uh, exhausted soda line, or it could be a low phase gas flow in a semi-open circuit, especially in pediatric patients where you are doing with a semi-open circuit and if you're keeping a low phase gas flow, or it could be a dead space ventilation, right? And dead space ventilation and low phase gas flow in semi-open circuit is a real-time scenario which can happen in a pediatric patient. So because the pediatric patients will have, because of a lot of connections, the T-tube length and the circuit length, there's a lot of dead space ventilation can happen. So that could be one of the possibility of rebreathing, right? So that's a very nice. Fine. Another spotter. Anyone can diagnose. Spasm, spontaneous breathing, bronchospasm, spark in appearance, bronchospasm. Great. So this is, as nicely mentioned by everyone probably, this is a typical shark fin appearance. Here you don't get uh, uh, a differentiation between the phase 2 and phase 3. And this is a typical scenario with the spasm, bronchial spasm. Now, this ETCO2 can tell you two things. One is that this patient is having a bronchospasm, so you need to treat this patient. Second thing, when you give the treatment, and if this ETCO2 regains its squarish waveform, that will tell you that your treatment is effective, right? So the use of this ETCO2 could be two. One, definitely you are diagnosing, is it classical with the COPD patient, or once we put a tube and patient sometimes goes into the spasm, perioperative bronchospasm, this you can get this shark fin kind of appearance. And when you deepen the plane of anesthesia or you give some bronchodilators, this should regain its spontaneous, the typical squarish waveform, and that can tell you that effectiveness of your treatment. So correct. I think everyone has given a correct answer. Okay, what could be this? So I'll tell you some clinical scenario. It's a 58 saturation. This is a pediatric patient of Pallet's tetralogy. So that's why the saturation is low, and you get this kind of inverted U kind of, not the typical four phase, it's sort of an inverted U kind of waveform. What could be the possibility? And we are giving 100% oxygen. The ETO2 is 91, I inspire oxygen is 95, so almost 100% oxygen we are giving to the patient. There is no rebreathing, IMCO2 is 0, right? The saturation you have to ignore because it's in a top patient. 858 is our usual induction time. So what could be the diagnosis? Any guesses? Okay, let me come to it. So this is a classical of tube leak. So what was happening that we put this patient on a ventilator with a 12 inspiratory pressure, 20 respiratory rate, the tidal volume, expired tidal volume of 40, which we saw that it was less. When we did, it was uncuffed tube, right? So when we gave a compression over here, we could find that the ETCO2 is coming typical squarish kind of waveform, right? So and we could palpate some amount of leak over here, and when we compress this, the tidal volume has gone up to 113 expired tidal volume, right? So this is a uh, classical of leak, right? So inverted U kind of waveform in a pediatric patient, uncuffed tube. This is classical of tube leak, right? Okay. Can you diagnose IE ratio from EtCO2? How many says yes? So if I put a EtCO2 waveform, can you diagnose what IE ratio this patient is getting ventilated? Any guesses? Can we guess? Yes. Great. Okay. So people who are saying yes, what is the IE ratio for this patient? What could be the IE ratio of this patient? 1:2, 1:2, 1:2. Okay. 1:1.5. Good. Great. New answer. Okay. So I'll tell you, how do we identify the IE ratio from this? So if you look at the phase 2 and phase 3 is your expiratory waveform, or it's an expiratory phase, right? The phase 4 and the end of phase 0 or phase 1 is your inspiratory time. So this is your expiratory time, this is your inspiratory time, right? Both looks same. So the IE ratio here is 1:1. Okay. So this was 1:1 IE ratio. Okay, I'll give you another chance. IE ratio of this patient. 1:3, 1:2. So this is your expiratory time and this is your inspiratory time. Almost inspiratory time is almost half, less than half, right? So IE ratio is 1:2. So 1:2 is the correct answer. Okay, one more scenario. What could be the IE ratio of this patient? So this is your expiratory time and this is your inspiratory time. It is almost 25% of the expiratory time. So the IE ratio is 1:4, right? Okay, great. Now a few spot diagnosis. You just have to tell me the diagnosis. I'm not going to tell you anything about this. Time starts now. Disconnected. Correct. It's a sudden disconnection because EtCO2 dropping down to the zero. Sudden drop in EtCO2. It could be disconnection. It could be kinking of the tube. It could be a defunk of the CO2 analyzer. Right? It could be anything. But for classical scenario is a disconnection. Correct. Next scenario. Spotter. Time starts now. Hypercarbia. What could be the reason for hypercarbia? That I want to know now. So you're diagnosed, but what could be the reason? Rebreathing, hypercarbon, hyperthermia, obstruction, increased production, hyperventilation due to high BMR, CO2 insulation, hyperthermia, rebreathing. Great. So diagnosis is high EtCO2. Obviously, CO2 production is high. Almost adequate ventilation. You see the temperature, 38. It's hyperthermia which is producing high EtCO2 or hypercarbia, right? So the correct diagnosis is hyperthermia. Okay, what could be this? Laparoscopy, let's come to this. Laparoscopy would not come because this is a spot diagnosis. Temperature is high, so that's why this is this thing. Thyrotoxicosis can be possibility. Yes, tachycardia, hypercarbia, higher this thing, but under anesthesia with thyrotoxicosis, temperature going half is a kind of strong kind of scenario, which will cause a lot of hypertension, which was probably not the case here. So the spot diagnosis is hypothermia, I would this way. But good, at least people are thinking that's a nice thing. Okay, coming to this one, what could be the diagnosis? So embolism. Again, this is a pediatric patient. 115 is the heart rate, 53 by 34 is probably routine pressure for him. CVP of roughly around 11. Saturation 19, again, this would be a top patient, so saturation is low. Pulmonary embolism, leaking, pulmonary embolism. Dynamics looks okay, normal for this patient. Hypotension, esophageal intubation. Great. So let me come to the this thing. Why it is not a pulmonary embolism? So there is no exponential decrease. There is no washout kind of curve. You have seen this patient is getting ventilated and slowly the ETCO2 is going down to zero, right? And as I told you, it's a pediatric patient. Hemodynamics are really normal, right? So this is a possibility. Only I think Aza Gurani has given the right answer. It's an esophageal intubation. So what would happen is this that this patient was put on a uncuffed tube in a this is a pediatric patient. So uncuffed tube was placed, and by when we were fixing or when we were ventilating, the tube would have got slipped into the esophagus, and that's why it is coming with the each respiration. It is coming with the each respiration. Now, from where this CO2 is coming, because there is some amount of CO2 which is getting produced in the stomach, so which is bringing out this, and it is coming with the each waveform, right? So this is the classical case of esophageal intubation. This is not a pulmonary embolism where you will get an exponential decrease over 1 or 2 minutes, right? So this is esophageal intubation. Correct answer by Aza Gurani. Okay, what could be this diagnosis? Malignant hyperthermia. So there is a malignant hyperthermia. There could have been a tachycardia, which is not there in this case. From SpO2 graph, I can say this. So this is nothing. This is just to play with your mind. So machine can defunk your machine can give a problem to you. I have changed the scale from 0 to 40 to 0 to 20. Your capnometry is 31. The reading is 31, which is normal, right? It is not abnormal. Only you can see the spike in the waveform because I've changed the setting of the scale. So from 0 to 40, the scale has become 0 to 20, and that's why it is. But capnometry is normal, and you're the same. It is just the change of, it's a machine issue, probably. Okay, spotter. So this is a 1 minute vital sign chart from 9:36 to 9:43. You could see this 31, 30, 28, 11, 26, 28, 30, 31. What could be the diagnosis? Any guesses? Low cardiac output, decreased cardiac output. If it is a low cardiac output, then why the ET would have started coming up over here? Embolism in 1 minute, again it has recovered. Disconnection, vagal stimulation. Great. So this is a pre-arrest kind of scenario or near arrest kind of scenario where ET has started dipping 31, 30, 28, 11. You see the pressure reading 142 by 11 to 112 by 65, 75 or 46, unrecordable. And then we did something over here, and his pressure started improving, and your ET started coming up. So this is kind of a near arrest kind of scenario where some intervention was happened between 9:39 and 9:40, and that's why it has got sudden rise in ETCO2. Pulmonary embolism will not behave like this. The sudden drop will not happen unless it's a massive embolism. And if it is a massive embolism, it can cause this kind of hemodynamic disturbances. It would not recover so soon first. So pulmonary embolism is the thing. Vagal stimulation can be it's a vagovagal uh, vasovagal shock and cause bradycardia induced hypotension could be possibility, and probably atropine would have given over here. So it's a near kind of shock or cardiac a near arrest kind of scenario which would could have done this. Right. Thank you. I hope I've done the justice to the thing. So got a good compliment from Muralidhar Kanchi sir. Thank you, sir. I want to.
Thank you. Thank you, sir.
Over to you. Over to my
Uh,
screen coordinator. Yeah.
Yeah. Dr. Rahat and Dr. Lavanya, just see if there are any questions in the chat box. I think chat box is most of answers only.
Yeah, looks like
Yes,
that.
ma'am.
Lot of answers. There are no queries. Yes, ma'am.
So I'm happy to receive any abnormal ETCO2 graph if you are getting. I'm happy to receive those, and probably I can incorporate in my presentations also.
So I think last time Curar Cleft had asked, and today you have explained it so well.
Yeah, thank you, ma'am. Thanks a lot. So my only thing and my only request to all the people who are listening is that when you look at the ETCO2 curve, this ETCO2 tells you a lot of things way ahead. I mean, probably 1 or 2 minutes ahead, it can tell you that what is going to happen. And if you can diagnose from that thing, you can have a very good outcome of your patients. You can actually avoid the scenario which can lead to havoc unnecessary. So, and as rightly been mentioned in closed case claims of American Society of Anesthesiologists and European assay, that if you have a ETCO2 and pulse ox, you can actually prevent a lot of complication, perioperative complication, morbidity and mortality can avoid. So, ETCO2 is a very wonderful tool. I'm just sharing my mobile number in a chat box. The only reason is if you get some uh, good waveform, please do send me. I would be I would be happy to receive those abnormal waveforms.
So,
All cases you have explained very nicely, Hetal sir.
Thank you so much, ma'am.
Rekha madam is also here.
sir,
Yes, ma'am.
yeah. Just ask when we see the capnogram, whether to see the numerical value is important or the waveform is important. I think
So
it's both.
first, as I told you, first is that you have to see that your waveform is abnormal or abnormal.
Yes, sir.
Okay. Then you look at the capnometry, your reading, right?
Yeah.
So I would say it's both is important.
Mm.
So sometimes what will happen, your capnometry reading will be normal, but your waveform could be abnormal, especially in a bronchospasm condition where your ETCO2 could be about 38, 40, right? But you can have a star shark fin kind of appearance, right? or in case of curare cleft, where your capnometry still not, could be normal, but you could see the notch in phase 3, right? So it is first you identify the waveform. First diagnose that whether there is waveform is having some abnormality. If the waveform is having some abnormality, it will tell you something, and and start poking that question to you, that what abnormality, whether it's a cellular level, or it's a metabolism is at stake, a circulation at stake, or it's a ventilation at stake. So you will come to know. Capnometry or the reading is actually the byproduct of that waveform, right? So merging both would definitely tell you that where what your diagnosis could be. And I'll tell you the shape of the waveform will tell you a lot of things, lot of things. And now since I've explained you in notch in phase 3, you can actually diagnose, or sudden drop in EtCO2, you have a 4 kind of pattern. So once you identify those patterns, you actually know what is happening. So most of the time, what happened with the case scenario which I put was the lady which was coming from overseas on OC pills, and there was a drop in EtCO2. Most of the people would think of pulmonary embolism, right? Because of hypercoagulable state, which because of the prolonged air travel and OC pills. But that was not the case, right? So identifying those patterns is very, very important.
Hmm. So I think you have explained very well in the exam. So I think Hina ma'am will also agree with me that these are the basic capnograms which we show to the students. And if
Yes.
they can answer in whatever you have told, that's more than enough.
Yes,
At
Madhuri
least for
madam.
the PG exams,
Yeah, agree.
isn't it? So what about, sir?
Yes, ma'am.
So what about like all this capnogram in the ICU?
It will tell you the same story.
Anything? Same story.
Yeah, same story. Ultimately, you're ventilating those patients. Yes, what will happen is in CPAP, you would see some changes in our CPAP where patient is spontaneously ventilating. Probably then you can see whether even from
Right.
EtCO2 in ICU, you can actually diagnose that whether this patient is ready for extubation or not. So let's say I have put some patient on CPAP where he's not probably come out of or he's not ready for extubation, right? So he would have a shallow breathing with higher respiratory rate. So the you can see the typical change in the EtCO2. When you see the typical squarish waveform with the normal respiratory rate and normal EtCO2, you know that this patient, probably no need for doing an EVG also. You can straight away extubate this patient. So again, I mean, it's just the clinical scenario which can tell you. And I think probably the same thing will happen. Hypotension, low cardiac output, maybe pulmonary embolism, if there is an orthopedic case, which is a polytrauma case, which has a multiple insult and possibly having prolonged immobilization, they could go on will have a DVT and pulmonary embolism. So again, it will tell you the same story. It will give you the same story.
Yeah, Dr. Hital, thank you very much for the lovely class. We have another meeting also to start at 7:40. So in the meanwhile, I have to appreciate what you have done for the class also. Thank you very much. So this is a small felicitation from the ISA National.
Thank you. Thanks a lot.
Yeah. And then Dr. Lavanya,
Yes.
yourself, and Dr. Farheen, thank you very much for anchoring this class again as a screen coordinators. And thank you for being very much attentive during the class and taking all the whatever the questions being raised there. No? So I think my meeting is just going to start in 1 minute. So we'll finish this class now.
Sure, sure.
Thank you very much. Thank you everyone for joining this class. And
Thank you, sir.
Thank you,
next
sir.
time, see.
Thank
Yeah.
you.
Thanks a lot.
Thank you, sir.
Thank you, sir.
Good evening, everyone.